Welcome to the latest edition. We're in series 7 of leadership and culture in healthcare, and we are talking all things clinical leadership. And I have the fabulous Jugdeep Dhesi, who is currently a clinical leader, but also the president of the British Geriatrics Society. So, Jugdeep, why don't you say hello? Why don't you describe? You've probably got multiple jobs, I'm sure. Most people in your position probably do what you do. And maybe how did you get to doing these roles that you are doing, just to give someone an insight into how you become that clinical leader?
Yeah, no, thank you, Matthew. And great to have the opportunity to chat to you today. So yes, my name's Jugdeep Dhesi. I'm a geriatrician at Guy's and St Thomas's. I'm a professor of geriatric medicine at King's College London and president of the British Geriatrics Society. I'm also just at the moment demitting from a role as deputy director at the Centre for Perioperative Care. So my journey, Matthew, that you're asking about, well, I was born and brought up in Essex, first generation immigrant parents from Punjab in India. I went to Leicester for medical school, where I received absolutely fantastic undergraduate and postgraduate training. And I stayed up there to do my house jobs and my SHO jobs. I then moved down to the southeast to train in geriatric and general internal medicine. Worked at a variety of district general hospitals across the southeast and also at King's and St Thomas's. And I completed my PhD examining neuromuscular function and vitamin D at King's during that time. And then I think kind of whilst I was doing my clinical jobs, I was on maternity leave, and as an SPR, kind of towards the end of my training, saw an advert for a clinician to help to start the POPs, Perioperative Medicine for Older People, project at Guy's and St Thomas's with Danielle Harari. And it was really kind of that opportunistic kind of chance that I took to get involved in that project, which has led essentially to the last 22 years of working to establish the specialty of perioperative medicine for older people. As a clinician and as an academic, that's led to local and national leadership roles. But also, whilst I've been doing that and focusing on perioperative medicine as my subspecialty, I remained very much involved in the overarching specialty of geriatric medicine through various roles at the British Geriatrics Society. And it was really that led to me being elected president of the BGS 3 years ago.
So I love talking to people who saunter through their CV as if that was plain sailing. And I'm taken by what Sheila Reardon, who you will know as a colleague geriatrician and another trust, who she talked about at the end of her episode about actually sometimes it's quite tough for women, especially as you've just described, doing your specialist training, doing a PhD and having children and then becoming a consultant, as if it was just walking down the street to get a pint of milk. I mean, that in itself is an amazing balance, isn't it?
It is a balance, but I think, those are the challenges that so many of us kind of face in our working lives, both in medicine and of course, in lots of other sectors as well. And of course, it is a real challenge, particularly for kind of women, for people from different types of backgrounds, ethnic backgrounds, socioeconomic backgrounds, all of those things that kind of factor into it. I think what that though means is that you do bring a particular personality and background to the roles that you then take on. And it gives you so many skills, being able to juggle, to communicate effectively, to be an effective networker. But that's also, you've got to have the right people around you to be able to do that, both personally and professionally as well. I think I've been very lucky to find those people in both of those sector kind of parts of my life. But there's also something about seeking those people out as well and making sure that you're making the right choices around who you surround yourself with. So yes, it's not quite like popping out for a pint of milk. And sometimes, of course, you do feel like popping out for a pint of beer instead when you've had one of those particularly difficult days. But it is also what makes things enjoyable.
Yeah. And give people a little bit of an insight into, those 20 odd years ago when you were doing your specialist training. What had attracted you to the geriatrics specialism at that point? Because it was quite, I think I'm right in thinking, quite a male dominated world at that time, geriatrics. And I think about your colleagues, there was a lot of men on the Guy's St Thomas's that I remember. And also now, I think the highest proportion of people going through training are women into geriatrics. So the world's changed. So what was interesting back there that posed your interest?
So it was interesting how I came to geriatric medicine, because after I'd finished my SHO jobs up in Leicester, I'd actually just, at the time you used to almost get offered registrar training posts. And I'd been offered one in neurology and one in endocrinology, and staying in the East Midlands to do that. I actually had 6 months that I could take off kind of for various reasons, and I went off traveling for those 6 months. And it was during those 6 months when I had a little bit of distance from the amazing role models that I'd had in neurology and in endocrinology that allowed me to think about what was it that I actually enjoyed about medicine. And I used the opportunity to make lists of pros and cons of different specialties in medicine. And it kept on coming up with kind of geriatric medicine, really, partly because I'd realized that I liked looking at the whole person. I liked looking at multiple long-term conditions and polypharmacy and all of the kind of issues that raises. I liked using an evidence-based approach to the way that I practice medicine, but bringing that to the patient rather than the condition. And I also really enjoyed the interface between physical and mental health, healthcare and social care. And so when I added that up, that didn't look like neurology or
That was
endocrinology.
geriatrics. Yeah,
That was geriatric medicine. So actually, that was a real epiphany being away over that time. And that was when we made that move from moving away from Leicester, which wasn't what we'd expected, moving down to London to a unit that was well recognised for the training that it provided, and making that step into this field.
What a great unit to join, because it had all that pedigree anyway, with amazing research credibility as well. So let's think about the role that attracted me to talk to you, which is being the president of British Geriatric Society. So just for those that are listening, help people understand what does a president of a college get up to? Is it all just medallions and dinners or what's going on? What have you been up to as the president?
Yeah, so the British Geriatrics Society is a really great place to be. It's now actually one of the biggest medical specialty association in the country. So we have 5,700 members across the 4 nations, multidisciplinary, although the majority of our members remain to be consultants. So a broad church, really. Its work kind of focuses very much on improving healthcare for older people. And that's always the thing that we always come back to as to being the mission that we're about, because of course you can get distracted by so much stuff that's going on across the wider health and social care landscape at the moment. So what do I get up to? So I work very closely with a very small office team, but also a number of voluntary officers at the BGS. We have 5 vice presidents for policy, for education and training, workforce, clinical quality, and for research and academic affairs. And each of those teams kind of then works with other colleagues across the country and internationally to align their work plans to the strategy that we set and the operational plan that we've developed alongside that. So it's very much giving direction kind of for the overall team, ensuring that we are delivering against our vision and our strategy, but also trying to inspire and motivate people during very challenging times at the moment. We're asking clinicians to not only do their day jobs, but then commit to delivering in these roles, which are voluntary roles and often done in people's own time. So it's about inspiring and kind of supporting teams, other team members to be able to fulfill their aspirations and ambitions as well. So that's kind of, and of course there is a ceremonial part to this as well. You know, you do get invited to various kind of dinners and so on. But of course there you're also there to represent the workforce who are contributing to improving healthcare for older people. So lots of discussions and making sure that people are aware of the issues that we're really facing today. And I think that's really interesting because, of course, we've all talked about the aging population for years. You know, that was featuring in people's slide sets 20, 30 years ago. And yet it's a little bit like that film, isn't it? Don't Look Up. When we've seen this tsunami coming towards us, or this asteroid coming towards us, but we've kept our kind of heads down and worried a bit about it coming, but not necessarily adapting what we need to adapt to be able to deliver a healthcare which is value-based in its approach. So I think my role is also to be getting those issues heard out there and making sure that they are informing the way that we develop the services and our workforce for the future.
And give people an insight into what's it like being that clinical leader, that figurehead, when you're having those those influential conversations, because you will have no doubt been invited to Secretary of State or other appropriate fora, into NHS England, into other kind of joint approaches with other colleges. What's it like to hold that clinical leadership role at that point, and what are you doing to influence those around you?
I think that's also a really interesting point, actually, Matthew, because until recently, we were finding it very difficult to have the voice of geriatric medicine heard at those kinds of tables. And I think that's what attracted a lot of us during COVID, particularly to say, actually, we need to step up to the plate and kind of contribute to the work of the BGS to make sure that that voice is being heard. We have developed healthcare systems such that they are very organ-based or condition-based, and we haven't necessarily looked at things from the viewpoint of the biggest user of healthcare, group of healthcare, which are older people. And so it's actually taken us a few years to start to get invited to the right tables. And that's required a mixture of us lobbying, writing, generating the evidence, being consistent and persistent, using different communication styles to be able to get ourselves into those rooms. And I think we're really pleased, actually, that we are now being heard differently to how we were being heard 5 years ago. And I think that's down to us having worked quite hard at being clear about our messages, being consistent between us, coming up with some clear definitions as well, which really helps. But then mapping out really all of the different organisations that we do need to work with to be able to move this agenda forward. So a bit of that kind of stakeholder mapping kind of exercise almost that we've had to do at our kind of organisational level as well. What's it feel like now, kind of being in the room? I think we're pleased. The first thing is that we're pleased to be in the room. I think personally, you often do feel the pressure of representing those 5,700 members who previously have felt unheard in the room. And so trying to make sure that we are engaging with our membership on a regular basis, that I'm getting out and talking to people, that I'm not sitting in my ivory tower of Guy's and St Thomas's and King's, but really understanding how people are feeling out there, working day to day, delivering services in very challenging times. So it's really helpful to be able to have those connections with people, to be able to then work effectively in those settings. And I think in some ways, maybe my kind of background in perioperative care has been really helpful for that, because of course there we had to bring together surgeons, anaesthetists, geriatricians who hadn't traditionally worked together in settings outside of hip fracture, to be able to develop a new model of care, get that established in one hospital and then translate it across other settings as well. So I think that's been really helpful for me to be able to kind of understand things from different perspectives across the healthcare setting.
And I guess, when I think back, it kind of echoes because I used to work in that patch of London, remembering when you, Daniel Harari, and others probably set up that approach. It was pretty groundbreaking, wasn't it? Because, I imagine it was quite a tussle with anaesthesia and surgeons and different parts of the clinical realm within the hospital. But now it's a normal way of doing business, isn't it? And the right standard. So you've no doubt learnt a lot from those tussles that you take into all the other things that you do now. I call them tussles. They were probably more fraught than that, perhaps.
No, there were definitely fraught times. I can remember some very difficult conversations in various lifts or shuttle buses, kind of encountering other colleagues from other specialties who couldn't kind of understand why they would need to change the way that they were delivering care. And again, it's interesting talking about POPs, particularly with people who don't work in healthcare, because I think everybody recognises that the biggest and fastest growing cohort of people having surgery are older, whether that's because of degenerative disease like hips and knees, whether it's because of cancers, or whether it's because of vascular conditions. All of those things happen as people get older. And of course, patients don't come along with just their surgical pathology at the age of 75. They come with those multiple long-term conditions, with frailty, with cognitive impairment, lots of things that aren't recognised often either. And then it's not surprising that so many of the complications that we see on surgical wards are medical. They are lung infections, kind of cardiac events, delirium, falls, deconditioning. And I think it was really that kind of experience as a medical registrar that really attracted me to working in this field, because we could clearly do better for that group of patients if we could get assessment, optimization, shared decision making better at the front end. Then we could make sure that we were supporting people properly through their post-operative journey as well, and helping people to get home in a safe, timely, efficient way. And it was that kind of, establishing that change, I think, that has helped me to understand how to influence change in other sectors as well. But also the importance of data to be able to support that. I don't think we would have been able to establish POPs locally, nationally or internationally without having a focus on embedding a research programme alongside the clinical service, so that we could evaluate clinical and cost effectiveness of the service that we're providing, and constantly iterate it, working with our patients and their carers to make sure it's really delivering what they want it to deliver.
I imagine also that there must be an element of supporting the broader clinical world to sometimes say no. And it's not in the older person's interest, especially when it may be an elective issues. I mean, acute surgical or accidents are different. I remember just my dear father, who's 95, and when he was ill last year, he's had hip and knees done in the past. And I remember having a conversation with one hospital consultant, won't name who it is or the discipline. It's like, well, maybe we should think about surgery. And he's like, oh, Dad's 94. Let's it's not good for him. And just because we can doesn't necessarily mean we should, does it?
No, no. And again, it's been interesting over the last 20 years in that when I first started kind of working in this field, we were more often trying to support patients to have surgery when they were being turned down for surgery because of their age.
Yeah.
And there has been a really good positive change
Yeah.
such that we're not exhibiting ageist kind of
Yeah.
approaches.
Yeah.
But you're right that, of course, now what we are often finding is that we are supporting patients to make often a choice which is not surgery or not a particular treatment because it's not going to deliver the benefits that they perceive it might, that the risks outweigh those benefits. There may be alternatives, but also, of course, there is the do nothing approach as well, which can be absolutely the right thing for people at particular points in their lives. And that's the work that we've been doing about embedding shared decision making through the POPs model.
Mm.
And we've got some really nice data kind of illustrating the impact of this. Kind of one of the studies that we've published recently has been looking at abdominal aortic aneurysms. And we've found where we have geriatricians, surgeons, and anaesthetists working together, 1 in 4 patients are choosing not to go ahead with their operation. So this is a huge proportion of the patients who are on the waiting list. And that's because it's not going to deliver what kind of matters to them.
Yeah.
And when we followed that group up, we kind of did find the patients who didn't have surgery, about 40% of them had died at a year. And so then we were a little bit worried. We're like, gosh, are we letting people die because of their aneurysm? But when we looked at kind of why they were dying, it was for other reasons. So not the aneurysm. And that really went to show that, of course, these patients were in the last year of their lives. And yet we were considering doing a big operation that wasn't going to extend their lives or give them any symptom benefit either. And then we've done some cost kind of health economics kind of on that as well, illustrating how this is also financially the right thing for us in that wider healthcare landscape. So it's, keeping an eye on what matters to the individual patient, but also looking at this with that value-based kind of approach as well.
Yeah, and all those take, I would say, pretty impressive clinical leadership, because actually articulating why not to do something is probably harder sometimes than just advocating, as you said earlier, to do things. But at least it's done from an evidence base, and it's done with the person at the center. Interesting. So when you sit back and look at your 5,600 members in the British Geriatrics Society and think about what's important, and bizarrely what we've not been talking about nationally for far too long, what would you say you would advocate in the broader geriatric world, geriatrician world, multidisciplinary world, that are kind of important things that we need to pay attention to, that clinical leadership makes a difference?
I mean, there's a lot, isn't there? But I think the first thing is that we really need to recognize the needs of the biggest user group of healthcare and recognize that they are presenting with multiple long-term conditions, often with frailty and sometimes with cognitive impairment or dementia. And then we need to align our services to the needs of that group, rather than us continuing to develop specialties which are organ-based or condition-specific. So I think there is something about how we align services to our patients as opposed to the way that we have set up things over kind of hundreds of years in medicine. And that probably is reflected a little bit, for example, in the POPs world, where it's about the patient, and we bring in the surgeons, the anaesthetists, and the geriatricians at the right time for that individual, rather than saying this is a surgical patient, which is the way that we used to describe patients, so they're medical or they're surgical. So I think that's the first thing, is actually making sure we're aligning services to the population. I think that then flows into making sure that we are developing, supporting, and retaining a workforce with that skill set who is able to support holistic care. And that's because all of the patient public involvement work that's done in pretty much in any specialty, patients always tell us that they want to have holistic care, which is seamless and joined up with a single point of access, and that it needs to focus on what matters to them. And so, you can look at hundreds of PPIE studies, but those nearly always end up being the same words that we come out with at the end of them. So I think the workforce needs to have the skill set to be able to deliver what patients and their carers are telling us that they need. That then probably does require integration, and that requires integration across physical and mental health, health and social care, and then integration, of course, across community, primary and secondary care services. And it's really great to see how integrated care has become a kind of more recognized kind of approach, and that we're all aspiring to that. But we still have got a long way to go to actually getting to a point where we're able to deliver integrated care, because that requires us to pool our resources, requires pooling of our tech and our digital approach. It requires pooling of our workforce. And it kind of requires us to, just bring all of those different things, and the funding, the third thing being, of course, the funding. So, so I think there's, clearly quite a bit of work that we need to do there on really pushing that forward. But we do have opportunities at the moment. And, as much as I think it's important to recognise the challenges that we're facing. And last night I was at the Age UK event where we were talking about corridor care and their report, that together with the recent National Audit Office report, all illustrating how we're missing opportunities to support people better. But we also need to kind of recognise where we are doing this well and start to share what we're doing more effectively, partly to be able to deliver those services, but partly also to motivate our workforce. I think just the constant negative stories in the press, which of course aren't stories, they are realities, but we need to match that with actually, here are some things that we can do better. Here are some places that are doing it. How do we learn from each other, scale up, spread, adopt those, adapt them to your local context? So I think there's quite a bit of work there around keeping our workforce motivated and engaged as well.
Yeah. I think the conundrum here, Jugdeep, is you mentioned earlier that the BGS, the British Geriatrics Society, have published a lot of great information. It has, and I'll put some of those in the notes for those that haven't read it. There's some brilliant things written by BGS over the years and recently about models of care. There's been a lot of random control trials across the world that focus on how do we support people, especially with moderate and severe frailty, in an exemplary way. And when I read all of that, we were doing some work in my organization recently, it's actually pretty clear, evidence-based wise, what should be done to provide a universal, episodic, and not everybody needs ongoing care, but kind of it's short-term interventions for everyone who is frail and severely frail. I think the evidence is compelling. And I sit here thinking, I draw some parallels. Go with me on this. In children, we have a massive evidence base for 0 to 5-year-olds, healthy child program. We offer a universal element to all, and then we do targeted work according to what's needed. I've never quite understood why that same approach isn't used for frail, severe and moderately frail older people, because the evidence base is there and the outcomes that have been tested are so clear. So from your angle, what's the blockers that kind of stop us moving into that type of mentality where we do something in a universal but very targeted approach for those that need it? Because the evidence is compelling.
It is compelling. And I think there are various reasons as to why we haven't been able to move forward in the same way as we have with children. I think Firstly, of course, there is an element of ageism that plays into this.
Yeah.
We do kind of look at children in a different way in our society than we do with older people. I think the second thing is, of course, the size of the problem, in that although we've got, a significant younger population, majority are healthy and well. And so, we're providing services for a smaller proportion of that kind of younger population. Whereas for the older population, generally kind of knowing that the average 75-year-old has at least 3 coexisting conditions, they are going to pretty much all be interfacing with healthcare on a very regular basis, and often it's with complex healthcare needs. So I think it's partly the size of the problem as well, which kind of makes it much harder. I think there is something around the fact that geriatric medicine itself hasn't been viewed as a specialty kind of over the years. It has been a Cinderella specialty. That is changing. We've got lots more enthusiastic, dedicated and motivated clinicians working in geriatric medicine than we have in the past. And there's a lot of work going on with us trying to support our medical schools to kind of ensure that they are discussing what the healthcare needs of the population are going to look like into the future and why they should be getting engaged in geriatric medicine. So I think the image of geriatric medicine over the years hasn't really kind of helped the cause either. But I think the other kind of things that really feed into this, of course, are, although we've got lots of evidence for the interventions that we can use, we still have less evidence in older people than we do in other condition-specific areas. And that's been great now more recently to see the NIHR being committed to funding studies which examine complex interventions in complex populations. So hopefully that kind of funding will allow us to continue to test new models of care and then support the delivery of those. I think the other issue around kind of NICE and with other funding bodies is that we have been very fixed with using traditional research methodologies, randomized clinical trials, which take 5 years to set up and, another couple of years to report. And then we're 10 years down the line before we can start to implement them. So we're really pushing hard on making sure that we're getting implementation effectiveness type studies being submitted for grant funding so we can examine them in real time and move things forward as quickly as possible. So I think there have been a number of challenges, partly around societal attitudes towards aging, partly the size of the problem, partly the fact that this feels complex, partly the great that we do have evidence, but probably still not at the level at which kind of we can really get this into NICE guidance and get it moving forwards. And that's why we've tried to align the work at the BGS to address each one of those areas with our 5 different vice presidents working hard on each aspect.
I think you put that very well, because it's not just one issue, is it? It's all of those. I could add in perhaps the reluctance of multidisciplinary working in this space. It's not that long ago that geriatricians were saying they're the only people that could do a complex geriatric assessment, aren't they? When actually, I think you need them as clinical leaders and overseers for governance and standards. But actually, great nurses, great therapists, and other people can do those things. So we've got all of that to play. I think I love your point about National Institute of Clinical Excellence and the National Institute for Healthcare Research. If they start publishing and funding the content that drives great neighborhood care and proactive care and the models that we're talking about in proportion to what's expended in the health sector, we'd be in a very different place, wouldn't we? Because it would be 40, 50, 60% of of their world kind of coming in the direction of this complex care. Yeah. Maybe that's the challenge.
It is the challenge, and we are leaders in the world in this. The
Yeah.
British Geriatrics Society is the society that all of the other international bodies look to for this kind of direction, this kind of challenge, and also our documents and the evidence that we generate. So we're in a really brilliant place in the UK to be able to move this forward. But it is really about bringing all of those different partners together to be able to do that.
So as we kind of come to the end of this kind of conversation, which has been fascinating, Jagdeep, and just listening to your insights has been great. What are you kind of quietly or purposefully kind of optimistic about? I guess you wouldn't do your jobs. You've got lots of them and do the president role unless you were passionate that things could be different. So give us a kind of glimpse into your world and what you thinking you're going to be optimistic about and want to see in the kind of next 12, 18, 24 months.
So I'm generally a really optimistic person, Matthew. I think you have to be, really, don't
Yeah.
you, in these roles? So what am I optimistic about? Well, I think that we do have an opportunity with the 10-year plan, with a kind of, it feels like a little bit of a resetting of the healthcare landscape at the moment, with people coming together to be able to talk about different ways of doing things. And I think, it's really nice to hear people with imagination looking at this and not being stuck in the old way of doing things. So I think that's really important. I'm optimistic about the role of clinical leaders in this. I think that's absolutely essential. And I think those clinical leaders need to be people who are credible clinicians, academics, who really do bring the shop floor experience to that world. And that's a bit that sometimes I kind of wonder about is, we often hear about people needing to go off on different paths in their career. And, do you go down to become a clinical leader early in your career, or do you stay a clinician? I think it's really important to have some credibility as a clinician back at your home base, such that it allows you that platform then from which you can speak with that credibility. But I think we've got some amazing people kind of coming into that space, and it's about how we support them to develop those skills. I'm really optimistic about kind of, despite all of the political shenanigans at the moment, I still think that in the UK, we really celebrate our diversity, and we do support people to fulfill their potential. And I think it's really important that we continue to do that. People from different socioeconomic backgrounds, from different cultural backgrounds, and geographical backgrounds as well, which is really key. We don't want this to be a London-centric thing in any shape or form. So I'm optimistic about that. I'm really optimistic for the BGS. We've grown our membership hugely in these last 5 years. And I think that's been because we've been more visible. We're being heard differently. We're in the public press. We're championing the rights of our older population to good healthcare. And we also, it's interesting that we wouldn't expect children to not have a pediatrician holding their care. And yet we do that for older people. And that's not right. So we need to be pushing that public awareness around their rights to the right care, which can be coordinated by a geriatrician. And when I say that, Matthew, I don't mean necessarily a consultant. It's a geriatrician with the right specialist skills from whichever multidisciplinary background is most appropriate. So I'm optimistic about that as well. So, generally, I think there is a lot to be optimistic about, whilst retaining an eye on the challenges and making sure that we are honest and open about what those challenges are. One of the things that we haven't touched on is that kind of balance between realistic choice and patient choice. And I think there is a very important distinction there, which we do need to have more honest conversations about. Like your dad, of course, he could have chosen a hip replacement at the age of 94. But was that really what kind of was a realistic choice for him? Would it deliver benefit to him personally And would it deliver benefit to us as a society as well? And those are difficult conversations to be having, but I think we need to rise to those conversations.
Yeah.
So loads, isn't there?
I mean, look, difficult, another word could be essential. We
Yeah.
need to move on from the difficult, don't we? Because actually it's an honesty of approach and saying actually that way. I mean, he's brilliantly articulate, and he said, no chance, I'm not having an operation at my age. And if I was really unwell, I wouldn't want an operation, and backed up by a fabulous GP's kind of then managing the pain really well. And, it's not all great on every day, but actually those are the essential things we have to get into as a society of not everything can be solved.
Yeah, no,
in
that's
that
right.
respect.
Yeah, and no, that's right. So I think there's lots to be optimistic about, but it does need to come with honesty, with listening, but then also with clear leadership. Effective listening needs to be translated into effective messaging and moving things forward.
Well, Jugdeep, you've given us a great glimpse into the world of geriatrics. I mean, we skimmed the surface and there was so much more, but it's been wonderful to hear your progression to be, consultant, Guys St Thomas's, a professor in academia, perioperative care society, now with the British Geriatrics Society as a president, what you've packed in your time, and that kind of real focus on data, evidence, change, leadership, and I just love listening to the passion about how the British Geriatrics Society, which for anybody that is listening, please go and look them up, look at their content. I'm not paid by them. I just think what they do is fabulous, and what their publications are cutting edge and the right things. So please have a look, and how the BGS will and becomes and is becoming more and more a really important element for change. And then, that whole area of how we need to get care wrapped around and the integrated approach for older people that is agnostic of organ and disease, as you say, but it's about the person and about everything that is interdependent in there, and how we can then make change with the 10-year plan. So the future is there. We are glad you are leading with the British Geriatrics Society for the time being. How long have you got left in your tenure as president?
So just till the end of the year. So
Okay,
lots to kind of pack in, but lots of great people coming on kind of following as well. So lots of, again, optimism there too.
Brilliant. Jugdeep, thank you so much for spending time talking about clinical leadership on leadership and culture in healthcare. And we look forward to hearing more of you as you finish off in your tenure as president. And I'm sure other things will follow. Thank you so much.
Thank you.